Yeah. So bienvenue. Thanks very much for joining us. So this is our weekly research conference, both at the Ottawa Heart Institute as well in the Ottawa region and further afield. And thanks very much for joining us today. Just a few logistics. Make sure you can use your Q&A feature on the bottom of your screen to ask your questions as the lecture is proceeding, and we will endeavor to answer them together with our speaker at the end of the session. And if you are interested in asking the questions live, we can actually do that as well. We can accept live questions and use the hands up feature at the conclusion of the presentation, and we'll be able to invite you to join the panel for the discussion. And if you have any technical issues, please use the chat feature on the bottom, and then we can make sure that Kelsey or Allison will be able to make sure you can connect without any technical difficulties. And then we are absolutely delighted today to have Dr. Girish Nair to give us some of the latest update in his exciting research. And I think you'll really find them very enlightening in terms of a lot of progress is made. And Dr. Nair is, of course, the director of our cardiology, electrophysiology and arrhythmia service at the University of Ottawa Heart Institute. He's a full professor in the Faculty of Medicine at the University of Ottawa, and also a member of the Department of, School of Epidemiology and Public Health at the University of Ottawa. And Dr. Nair was originally from the Jawaharlal Nehru Institute of Postgraduate Medical Education, which is one of the top institutions in terms of medical teaching as well as research in India. And it's in the Pondicherry, but I gather now it's called the Puducherry region in India. And then he completed his residency and in cardiology at the University of Delhi. And then we are very lucky to have him come to Canada in 2002, completed a clinical and research fellowship in interventional cardiac electrophysiology at University of Toronto and the Toronto General Hospital, where we were actually colleagues at that time. And Dr. Nair completed a master's in health research methodology from McMaster University in the same time frame. And then he got recruited by the McMaster folks, and in fact was faculty in the Division of Cardiology at McMaster from 2004 to 2012. And then we were able to, very lucky to recruit him to the Division of Cardiology here at University of Ottawa Heart Institute in 2012. And so I think folks do know that Dr. Nair, with his skill set and also clinical interest, is particularly an expert on complex ablations, including atrial fibrillation, ventricular tachycardia, and arrhythmias in adult congenital heart disease. And he conducts research on these conditions with a particular focus really on the important aspect of quantitative methods, and so that we can actually identify the most optimal scientific-based strategies and to actually get the best outcomes for our patients, and then effective knowledge translation so that it can actually be applied in the real world practice. And Dr. Nair is actually chair of the annual scientific session for the Canadian Heart Rhythm Society. And I gather he's actually going to be presenting to the international meeting in Copenhagen in the coming week, as well as in the coming month as well. And he's a primary panel member for the Canadian Cardiovascular Society Atrial Fibrillation Guidelines, which of course has been most influential in terms of changing clinical practice. And he's also a grant panel reviewer for the Heart and Stroke Foundation, CIHR. But I think the important aspect is that he has received several awards, including at McMaster University, the Ernie Fallon Award for Teaching Excellence. I certainly know Dr. Fallon, very well. He's really an icon in cardiology. So this is really a great recognition. And he also has, and the Dr. Nair has importantly peer-reviewed grants from CIHR Heart and Stroke Foundation, really allowing him to lead the major clinical trials evaluating treatment strategies for atrial fibrillation, and which we look forward to hearing from. So it's actually a great pleasure today to have Dr. Nair present for us on the topic evaluating interventions in cardiac arrhythmias, quantitative research strategy to determine the efficacy of arrhythmia interventions. Thank you so much, Girish. Really appreciate it.
Thank you. Thank you so much, Peter, for the kind introduction. Shall I go ahead and share my screen and start?
Yes, go ahead. Yes, I think this is perfect. Yeah.
Can everybody hear me well?
Yes.
Okay.
Yeah, looks good. I think once you put in presentation, it'll be perfect. Yeah.
Just doing that in a second.
Yeah, great.
All right.
Yeah, perfect.
So good afternoon, everybody. And thank you for the opportunity to present at Research Rounds. It's always a pleasure. I remember I presented in 2017 and have lots of follow-up to present from then. And, these are my disclosures. None of this should affect what I'm presenting. So, I didn't have a very organized research career, and I think there's a lot of serendipity involved in how I got here. And that plays a big role in clinical research, at least, not to mention basic science research, where a lot of important medical research has occurred out of serendipity. And so my goal today is to describe research projects that evaluate outcomes and effectiveness of interventions for cardiac arrhythmias, because that's what I do. And, focusing on what you do is more important. Since the time is limited, I'll just focus on one atrial arrhythmia. And I will go through my journey over the last 2 decades as to all the important questions we asked in this field and how we found answers to them and how we are planning to do so in future. So as Dr. Liu said, I did my internal medicine, cardiology, cardiac interventions from different places. And I lost a bit of time moving from India to Canada. When you come to a new place, you have to develop networks, contacts, and without those, you cannot complete, collaborative clinical research. And I was fortunate to have been hired by McMaster University and then the University of Ottawa Heart Institute. And with the help of these institutions, I was able to develop some research. And I'm always reminded of what Dr. Banting said. He said that you always have to ask why of every statement that is made and think out your own answer. So, I mainly trained to do clinical care and to perform complex procedures. I just didn't want to be an interventionist without questioning whether what I'm doing is right and is the right thing to do. So that is those are the questions I asked through the past 2 decades to find out answers to problems that I faced on a daily basis. Nobody can, succeed or do anything without excellent mentors. So on this page, I have a list of physicians who have helped me, along with a lot of members of our research team and the research team at UOHI that have helped us tremendously, helped me in particular in getting getting where I am now. These are some of my nominated mentors who have helped me. These are some from India here and from other centers in Canada, and some from McMaster University, including my thesis guides, Dr. Worcester and Dr. Roberts, from whom I learned a lot. I am indebted to our research team, including Sarika, who I see in the audience, and she was one of the people who helped us set up one of the clinical trials I'm going to discuss today. So what mentors do is they help you stand on their shoulders so that you can go up one step ahead. They allow imagination, and sometimes when your ideas seem quite not logical, they allow you to proceed with them. You make some end up making an impact, some don't, but they give you that freedom. And then they do put pressure by fostering competitiveness so that you don't slack and you do your part. So the topic of today is, today's topic is basically atrial fibrillation. And there's a lot of serendipity in this field, just like serendipity in medicine. This is Dr. Fleming, and he discovered penicillin while working in a moldy lab. He found that there was mold growing on one of the bacterial cultures and no bacteria grew around it. And then he discovered penicillin. So the condition that we're going to talk today, for those who may not know it, is atrial fibrillation. This is a cartoon of the cardiac structure, showing the two upper chambers called atria, two bottom chambers called ventricles. And the white cables are cartoons of the electrical system of the heart. And the electrical system and the resultant muscular contraction causes a normal sinus rhythm beats like we see here. And in this particular condition called atrial fibrillation, for many factors, due to many reasons and factors, you have a breakdown of the normal electrical activity in the upper chambers, and there are multiple chaotic beats that set up. And what that does is, on the surface ECG, you lose a smooth PQRST waves, and instead of regular atrial activity, all these squiggles you see are irregular atrial activity, which is a reflection of the breakdown of smooth and very laminar electrical flow in the upper chambers of the heart. Now, atrial fibrillation can be of three kinds. So one is, a person may have one episode in their life during a very particularly stressful situation, like post-bleeding, post-trauma, something of that sort, and they never have it again. But for the most part, in people less than 60 years of age, you have intermittent atrial fibrillation that occurs for a few hours or seconds a particular day, and then you have nothing, and then it may happen once or twice a week, once or twice a month, or maybe once or twice a year. And then there are some who transition from this intermittent stage, slowly progressing through more and more frequent episodes, longer episodes, until they are always in atrial fibrillation. And as they age, you see that a lot of these people with recurrent atrial fibrillation in their younger days transition to chronic and permanent AFib. And that is why we always feel that we should approach the problem, because prevention is always better than cure. And you to prevent these people from progressing, first from developing atrial fibrillation, and then from progressing here to this chronic persistent stage, which is incurable. So all our endeavors are directed towards preventing atrial fibrillation. And if people do develop it after all your preventive measures, then from progression to permanent AF. So with that, and why is atrial fibrillation important? This is actually one of the largest surveys assessing the global burden of disease. And this takes a long time to collate. So this was data based on 2010, which was published in 2014 in Circulation. And the color coding shows the prevalence of atrial fibrillation in different parts of the world. And as you can see, North America is especially in red with one of the highest prevalences. Now, part of it is good reporting and poor reporting in some countries. However, countries like China have very good reporting systems, and they have one of the lowest incidences of atrial fibrillation. And so is it in warmer climates compared to colder climates. So as you can see in Europe and North America, it's pretty high. So a lot of people have atrial fibrillation, and it's estimated that by 2050 or 2060, almost 20 to 40 million people in North America and Europe will have atrial fibrillation. So it is a problem. And we know that atrial fibrillation increases mortality independent of concomitant diseases. And it's associated with increased mortality risk if untreated, strokes, and heart failures, all of which put burden on healthcare systems and significantly impair quality of life. So the serendipity in this field occurred to one of our colleagues from Bordeaux. He's quite famous now. His name is Dr. Michel Isaguerre. And in 1998, while treating patients with atrial fibrillation and going into their heart, he discovered that the trigger for atrial fibrillation, the atrial fibrillation was set off by rapid electrical activity, mainly coming from the left atrium and the 4 pulmonary veins. So this is a venogram of a pulmonary vein. What he has shown here is he's put a catheter in and filled the pulmonary vein with radio contrast, and so you can see it. And when he put a catheter in the pulmonary vein, he found that there were electrical signals which occurred even before the surface P wave, which indicates atrial activity. So he was saying he discovered that for some reason, the pulmonary veins, there are usually 4 to 6 of them, 2 on either side, 2 to 3 on either side. And he found that they all had early electrical activity, even before atrial activity. The atrium is here, just outside of the pulmonary veins. And the other serendipitous observation was the patient was in normal rhythm, and suddenly he sees that in the pulmonary vein, there is chaotic electrical activity, following which the surface also demonstrates it. So with this came the serendipitous realization that for some reason in a lot of patients, atrial fibrillation originates because of chaotic triggered activity in the pulmonary veins. So knowing that, then we started unraveling it. So a lot of anatomical and pathological correlation was obtained over the next few years. And we found that when we dissected the heart out, that the pulmonary veins have got a lot of atrial musculature that is electrically active. And this is a cut section, longitudinal cut section of the pulmonary vein. All the light green sections are connective tissue, and these darker green ones with arrows are actually muscle fibers. And muscle fibers in the heart have electricity. And this is a normal, the panel on the upper left is a normal pulmonary vein. And this is from a deceased atrium where the patient had atrial fibrillation. You can see all the brown structures are atrial muscle, and all the dark blue pigmentation, stained pigmentation, is because of scar. And patients with atrial fibrillation had a lot of scar in the tissue. So that we understand is what generates electrical short circuits and leads to atrial fibrillation. Now, this is an anatomy of the left atrium. And then Dr. Isager and everybody else asked a question. So we know that pulmonary atrial fibrillation originates from these 4 veins. So can we go and electrically isolate them so that we can reduce atrial fibrillation? And initially, they started studying electrical signals and started burning. These red dots are burns, select areas where they saw signals from. But then they quickly realized that, at any given point in time, some veins are active and some are not. So they switched to a strategy of isolating all 4 veins right in the mouth of the vein. And then they realized that that can sometimes cause a problem by blocking off the veins or shrinking them. So then finally we set upon the established and currently used technique called wide area ablation, where the ablation lesion set is created quite outside the pulmonary veins so that you don't block off the pulmonary veins, which are essential, block off blood drainage into the atrium through the pulmonary veins, which is an important function of the pulmonary veins. So we don't want the electrical triggers from them, but we still want the pulmonary veins bringing blood back to the heart from the lungs. So we modified the ablation strategy, and then that was established somewhere in 2004 to 2006. So that's around the time I finished my master's and was going to do some research in my clinical domain. And my mentors told me, you need to focus and focus only on 1 or 2 things. So I thought of 3 or 4 lines of inquiry, and I focused. I'm going to present the 4 questions I asked regarding atrial fibrillation treatment, especially with catheter ablation. And I'll show you how I found answers to those. So the first question was, is catheter ablation better than antiarrhythmic medications, which was then the standard of care? People would get a bunch of antiarrhythmic medications or amiodarone, and then if they failed, then they would get a pacemaker, and you would accept atrial fibrillation. So in answer to that question, I and Dr. Nair, who was working in McMaster as a fellow then, along with Stuart Connolly and Dr. Carlos Murillo, who were some of my mentors, performed a systematic review of all published trials comparing catheter ablation with antiarrhythmic medications. And we found that in this small group of patients, in those days, there were very few randomized trials, that catheter ablation actually resulted in better arrhythmia survival. So that was one of the first questions that we asked. And based on that question, multiple other systematic reviews were done, and we designed this large randomized trial that checked catheter ablation and compared it to antiarrhythmic medications as first-line treatment. We completed this randomized trial, which showed that radiofrequency ablation was better, and it was published in JAMA in 2014. From the time you do a systematic review to time you get grants, do this, it takes many years. So these are not single center studies. They were done by multiple investigators in the US and Canada. So it takes time in Europe. So this is some of the details we won't go into, but these are the survival curves that show that radiofrequency catheter ablation was better. And to calculate sample size for this trial, we used our systematic review that we had performed. So, with the help of that study and then multiple others, we were not the only ones asking this question. And for guidelines to accept any particular recommendation, you need multiple large randomized trials that all point to the same answer to a problem. And initially, like I said, if you have for long-term rhythm control in patients with atrial fibrillation, you used any of these antiarrhythmic medications. But because of these trials, we have been able to bypass, and there's more and more evidence based on 2 recent trials saying that first-line catheter ablation should be the first line of treatment, can be the first line of treatment in select patients, not all. Mainly those patients who are relatively healthy, relatively young, and have multiple frequent episodes of atrial fibrillation that's affecting their quality of life. And this made it to the Canadian Cardiovascular Society guidelines. And because of a lot of the work we did, I was selected to be one of the panel members of the writing committee, which is not easy to get into. So the next question was, okay, so now it's established as the treatment of choice for atrial fibrillation. How good is it? So I brought out some of the large randomized trials of the last decade and said that, which showed that the 1-year survival, 1-year procedure success rate was about 65 to 70% at max. About 40% of patients to 35% of patients were requiring a repeat procedure or failing the treatment. So that brought us to the next question. What are the causes of treatment failure after catheter ablation? So when we started realizing this, we did a systematic review. I mean, for us to find out what is there, and this was done by Dr. Nair and myself, along with Dan Bellevue, who was one of our medical students here. We conducted a systematic review that was published in JACC, and we found out that the reason for durable, if you had durable pulmonary vein isolation, that is, if your lesion set was durable and the pulmonary veins remain isolated, you had a lower risk of AF coming back after catheter ablation. And this was very crucial because it told us that when you do the ablation, you need to do it well so that you don't have recurrences, because recurrences cost, well, first of all, the patient does not like having recurrences and having to undergo the procedure again. You put the patient at risk because none of these procedures are without risk. And thirdly, it's estimated that if you have a 40% recurrence rate, Ontario will have to spend $14 million more because they'll have to fund all the repeat procedures. So if you can reduce them, Ontario and the healthcare systems around the world can save a lot of money. So we went in and looked at our results. So we had a large cohort of patients, and thanks to our leadership, including Dr. Burney and our entire arrhythmia group, we kept meticulous records of all the procedures we did. This is a case in particular we did. And we also did, I also did some bench work. So this is a porcine heart that I went and did ablations in Georgia, Atlanta, to understand how lesions are made. So what we realized is this red tissue is all healthy heart tissue, and these white areas are the ablations we made. So we went and performed the ablations in a living animal model and then sacrificed the animal and then immediately looked at what happens. So you see, we developed a 3 millimeter deep lesion in the myocardium with our ablation. And so this is how you destroy certain tissue in the heart specifically to isolate, and this is what we do around the pulmonary veins. So we realized that some areas have, the lesions are big and thick, and in some areas they're thinner and can potentially reconnect. So with that knowledge, we studied all our patients that had reconnection. So we went back into their hearts and we looked at the circle we created. This is schematically presented in this diagram. We looked at all the areas that had reconnected and found two themes. We found that reconnection was more on the right side, around the right-sided veins, and on the posterior aspects of the veins rather than the anterior aspects of the veins. And we found that those who had, so we also compared this with patients that were undergoing procedures without good catheter contact. So around this time, we had a technology that told us how well our catheter was opposed to the cardiac muscle. So imagine this scale here is the catheter, and it's touching the heart muscle. So if it's touching well, you get deep lesions. If it's not touching well, you get weak lesions. So we also saw on the right-hand panel, there were many more reconnections if you had weak contact force between the catheter and the tissue, and fewer reconnections if you had good contact. And that is shown by this Kaplan-Meier survival, where if you had good contact force, you had a lower recurrence rate in pulmonary vein reconnection. And we realized that catheter stability and good catheter contact is what caused good lesions. So once we understood that why and what are the factors involved in reconnection and failure of catheter ablation, we said, how can we improve the success rate of catheter ablations? So that was the next question that we worked on. And after our review of literature and after our bench work, we sort of created, which is not unique to us, a lot of people are aware of it, but I've put it down in what we call the ablation matrix. So the factors affecting lesion formation during catheter ablation involve the following. One is the power or the RF watts or energy you use to deliver. So the higher higher energy you put in, the deeper and the more powerful the ablation is. Tissue contact, or the contact force with which the contact touches the tissue affects it. The temperature at the tissue interface. The damage to the tissue is caused by temperature at the tissue, at the catheter tip, causing direct coagulation necrosis and then bubbling of water within cells and destruction of cells. The catheter orientation and blood flow around catheter and tissue. So if there's a lot of blood flow, remember, we do these procedures when the patient is awake and not awake, is alive, and the heart is pumping about 4 or 5 liters of blood every minute. So what happens is the blood can flowing blood can act as a sink and take away some of the energy. And the third is stability of the catheter. So the catheter is ablating while the heart is moving. So if the catheter is not stable, you can't deliver good lesions. So based on this, we looked at, we were aware that a lot of our colleagues were using additional measures, which we called adjunctive measures, to improve the results. And like in our case, when we use contact force, our results were better. So again, I and some of our fellows and Dr. Nair and our entire team, We looked at all the adjunctive measures used during pulmonary vein isolation. We identified a bunch of them, which include, of which the most promising was adenosine testing to find out incomplete lesions, and contact force guidance, where a contact force feedback is given to the operator while ablating to create good lesions. So this is our contact force data, and using this, we and other operators in Europe, what they did is they used a technique of very meticulous contact force guided ablations around the pulmonary veins, and found that the results were better. But this was an observational study, so it was not a randomized trial. And they found that the survival of patients and acute reconnection was avoided in almost 90% of patients, which is all very promising. One of the downsides is that this was observational data. So in our field, people want large randomized trials. So this was an algorithm we created specifically to design a clinical trial. So we asked ourselves, how do we design a clinical trial for improving the efficacy of the procedure, the WOCA procedure, or the PVI isolation, wide area circumferential procedure? So first is you have to select patients that are likely to respond to WOCA. If you don't select patients that are likely to respond, for example, if you select a 90-year-old who's had atrial fibrillation for 40 years, they're not going to respond to this treatment. So you should not select them. So if they're likely, then you have to look at patients and select the right patients. So we found out that we should do a trial looking at how to improve results using catheter ablation, mainly in patients with paroxysmal AF, with structurally normal looking heart, and probably a patient of subjects, a subset of patients with persistent AF. Then we went and identified factors influencing durable PV isolation and good lesions, incorporate the recent advances in the ablation technology, and select meaningful clinical endpoints that are meaningful to patients, healthcare systems, and others. Otherwise, you may do something fancy, but if it's not clinically meaningful, nobody will adopt it. And then you have to select the appropriate trial methodology so that you have no bias. And then you want to look at two endpoints. The holy grail, as figuratively speak, is cure, which is not always possible. So then we look at reducing clinical AF burden, symptom relief, the ability to discontinue oral anticoagulation, delay or prevent progression to persistent and permanent AF. And each one of our Arrhythmia service members is doing one of these things at least. So Dr. David Burney is doing the OCEAN study to look at whether you can discontinue OAC. Dr. Nair is looking at persistent or permanent AF. Dr. Golian is looking at clinics and how to streamline patients coming in. Dr. Sadak has done an analysis of all our redo patients to see how we can improve results in the redo patients and to understand what are the causes in redo patients. So each one of us is involved in finding answers to these. So what we did is we said, currently people are creating one line of circle, and some areas, the lesions are not strong enough or thick or deep enough, and there's reconnection. So we were brainstorming during our AF hub. At around that time, Dr. Messana and the institute started research hubs and focus groups, and we were in the hub. And David Burney always likes to say belts and braces, and I like to say double bagging. Our hypothesis was, what if you create another line around the first one? Will that help us create deeper lesions, prevent reconnection? So we said, why don't we evaluate that? And we started some pilot work, thankfully funded by the Division of Cardiology. I must thank the Division of Cardiology and the Academic Medical Organization, which gave us seed about $37,000 to start off some cases, because this was a new technique. So I and my colleagues did it here and showed it to everybody in Canada and said, why don't we evaluate this? We thought that the redundancy will reduce chance of reconnection, a wider lesion set will modify the atrium to a greater extent. It could also modify some of the other extra pulmonary vein triggers, which we know exist, but to a lower extent in some patients. And we also said, instead of burning heavily at one spot, if you spread the energy, it will be safer, because there are important structures around the heart that you can cause collateral damage, and you don't want to injure the aorta, the esophagus, the phrenic nerve, and the other structures that are around. So we said, why don't we evaluate this? And our plan was, if we introduced a unique form of randomization. Usually for most AF trials, a week or 10 days before the procedure, a patient enrolled in a clinical trial will be randomized to either the control arm or the experimental arm. Now, in our case, if one of the sources of bias is the operator cannot be blinded because he's doing the procedure. So if I'm doing the procedure, I will know what I'm going to do. So if I know upfront, a week in advance, that this patient is going to get only one circle, I may do that circle very meticulously and be biased and spend extra time because I know that is my only chance. If I know I am going to do 2 circles, I may be a little more lax creating the first one. So my colleague, it's principally my colleague, Dr. Redpath, who gave us this brilliant idea. So I have to, that's again the point, is that when you have many heads, they're better than one. And he suggested that. And what we did is, we said every operator who does the procedure will create the first line to the best of his ability. And then we open the randomization envelope. So we have every procedure in every center in Canada that we enrolled, there was a randomization envelope which was opened by somebody after the first circle was done. In this way, we decided that we would eliminate operator bias in doing the procedure. And then if the control arm, they would do some additional adenosine testing to see if their block was good and complete the procedure. In the experimental arm, there wouldn't be any adenosine testing, but we would do 2 circles. And so this is the trial enrollment. So we published the methods recently in American Heart Journal in preparation for the main manuscript. And we have completed the trial, I'm happy to say, and we have submitted it to Heart Rhythm Society, which is our premier meeting, as a late-breaking clinical trial. We'll know in a couple of days whether it's going to be accepted or not. And we're simultaneously submitting it to a few high-impact journals to see if they'll accept the paper for simultaneous publication, which is a long shot, but no harm in trying. I can't divulge any of the results because the results are under embargo, but we have some fascinating insights from this trial that our institution led and has got very valuable data that we'll share over the next 5 years to 7 years. We have at least 6 important sub-studies in this field we can publish. So we have done the trial to improve the success rate of catheter ablation. Now, the other problem is, a lot of trials will do some procedure and not assess the outcomes properly and then, declare victory, so to speak. So if you do not ascertain outcomes well, you will have a misleading answer to your problem. And why is it a particular problem in the field of atrial fibrillation? Typically, the kind of atrial fibrillation we are looking at, patients will have intermittent atrial fibrillation. So if you have, say, X number of patients in a clinical trial, typically we do Holter recordings at, say, 3 months, 6 months, or 12 months after the procedure. So if the patient wears a Holter monitor 3 months, 3 patients may have atrial fibrillation. The ones in black are the ones with atrial fibrillation. And then you do a 6-month one patient may have it. But in the intervening time period, a few have had atrial fibrillation, some of whom may not have atrial fibrillation either during the first one or the second one. And so you miss them totally. So you may overestimate the success rates. And typically we do a 14-day Holter monitoring 3 times, which means in a 365-day period, we monitor for about 52 days. So this is a relatively intensive, invasive monitoring strategy. A lot of centers will not use that intense ones, but we use that. The gold standard is actually putting in what is called an implantable loop recorder, where you put one in under the skin and it automatically measures or records atrial fibrillation for 2 years. So that's the gold standard. So Dr. Rudy Uni and a bunch of our internal medicine, cardiology residents did an extensive, under my guidance, did an extensive systematic review of all published randomized trials between 2007 to 2020 to 2021. This is a long time period, and there was an explosion of randomized trials. And we identified multiple monitoring strategies, with very few of them using implantable pacemakers or loop recorders, and very few using 2-week loop recorders on multiple days. And what we found is that compared to intermittent monitoring, continuous monitoring gave you higher outcome, higher detection of atrial fibrillation. How is this important? Because if you do 2 trials, one uses intermittent AF monitoring, it will say that the success rate was 70%. But if you use continuous monitoring, your success rate falls down to 55%. So how you determine the outcome is very important, more so in paroxysmal AF, where the episodes are brief and intermittent. In persistent AF or long-lasting AF, the patient is in AF for multiple days, so it's easier to detect whether they failed ablation or not. The last problem is, once you do catheter ablation, there is a degree of cardiac denervation, and patients may now start having asymptomatic atrial fibrillation. Prior to the ablation, they will appreciate atrial fibrillation and come into the hospital saying, "Doctor, I'm having atrial fibrillation." So even if they're not wearing a monitor, you can do an ECG and pick up atrial fibrillation. But after ablation, they may not even realize. So that was one of the challenges. Then we did what is called regression analysis to look at the duration of monitoring. So if you look at this regression slope, and this I must thank Lily Chen and Dr. Wells, because it's conceptually and to implement and do this analysis was very challenging. We showed that if you monitor for brief periods, like 5 or 10 days, really the duration of monitoring does not make any difference. But you can see these are all trials that use identical ablation, identical patients. You can see how the outcome rates are all over the place, right? So this was, I think, a seminal finding, and we hope to influence guidelines to have a standardized monitoring of patients in arrhythmia trials, preferably through an implantable loop recorder, based on this article, which the CJC accepted in its open version. It's already online. This is a journal pre-proof. And along the same lines, one of my colleagues, Dr. Andrade, who presented research rounds, I think, not research rounds, the ovation rounds last month, he used a different strategy. So he completed a trial where all patients had implantable loop recorders. So based on our hypothesis, he did a simulation study. So he opened up windows of monitoring so they had 2 years of monitoring every day, captive. But what they did is they measured 24 hours of monitoring at 3 months, 6 months, and 12 months, simulating what is done in clinical trials. And what they found is that if you take implantable loop recorders as the gold standard, sensitivity and negative predictive value of 100%, then all the 24-hour trans-telephonic monitors fared poorly. And the best one was symptomatic, was 14-day AECG at 3, 6, and 12 months, which had arrhythmia-free survival detection, which is lower, and approximating that with implantable loop recorder, sensitivity and specificity. So for burden, it was very close to ILR, and that's why we are happy that in the recently concluded trial, we used this strategy. If we had not analyzed our results and not being cognizant of of this bias in IC trials. When we sent our article, they would have definitely brought it down because they would have said your monitoring strategy is very infrequent. Now they can't say much because of our work and this work from Dr. Andrade. Implantable loop recorders are still not the standard of care. They are expensive. Each loop recorder costs us $4,000. So the trial we did, if we had to put implantable loop recorders, we would have needed almost $4 to $5 million to complete it, whereas we completed the trial in about $1 million from CHR and other sources. And we have got a monitoring system which almost is as good as an implantable cardiac monitor. So you have to balance pragmatism and daily practice when you do clinical trials. And sometimes you have to take what you call, you have to accept certain, certain degrees of bias in a trial. Now, the trial that Dr. Andrade completed was entirely industry driven. We did not want to do that, and we wanted to do something without a lot of industry involvement, and mainly through where we had full control over the design methodology. So in this, a simulation study, they felt that the sensitivity of AF detection approaches 60% with a negative predictive value of nearly 80%, and an agreement with AF determination in nearly 80% for 14-day Holter monitoring exceeding 28 days of monitoring. And we have almost 52 to 60 days of monitoring in our trial. And trans-telephonic patient-driven monitoring helps only in 4 to 5% of cases. So it's not very helpful. So we are so glad we did this to guide our design of our clinical trial. And with future steps after this, we are going to do what's called an aware-to multi-center RCT, where we are hoping to improve the catheter ablation results using lessons learned from the AWARE trial. We have the backing of now 18 collaborative centers in Canada. I have applied to CHR, was rejected twice. The last time around, we got scores of close to 4. So hopefully as we apply another 2 or 3 times, I will get higher scores and we'll get money from CHR, because again, we are not very keen on losing our intellectual freedom and research freedom if we lock into completely industry-driven trials, though there will be some in-kind contribution with loop recorders from industry. And with that, I will stop here because I will answer questions. I've got about a few minutes left. One of my mentors always told me that less than 1/4, that most people will consider your research work less than 1/4 as important as they seem to you. So we always keep that in mind when we pitch our grants and study ideas, and don't be too sure of one's own wisdom, because that can cause you to create mistakes and errors. Thanks.
Well, thanks so much, Girish. I think you're too modest. I think you really actually done an amazing job, and that's, even though it's a serendipity, but I always say that luck, favors the prepared mind. So I think it's really you being very persistent in asking why, right? And challenge the kind of accept the dogma, and also I think your research methodology background. And it's really controlling for bias. That's so important. Otherwise, it leads us astray, and that's why the randomization and the clinical trial design are so important. I love the the establishment of the cheaper alternative endpoint capture, than the $4,000 per patient endpoint. But nevertheless, I think really actually underscores the importance of asking questions in a very methodical fashion, right? Can then move the field forward and then, continue to ask the next questions. Yeah, so I think with your persistence, you will be able to get AWARE-2 funded. But congratulations on the AWARE trial as well. I certainly remember, in terms of your efforts and getting the funding and getting the study done. That's really a tremendous effort. So there are some questions, and maybe we can entertain them. I have my own as well. And so this question is from Jim Robley. It's an excellent presentation. And so this is kind of more related to clinical practice aspect. That is, based on your work, how long should the patient be kept on anticoagulation following ablation? It's one of the very common questions. Certainly, people ask regularly. Yeah.
I think that's a very important question, and I alluded to this in my presentation. So the answer is not simple and straightforward. So I'm going to start with what is there in the Canadian guidelines, because we're talking about Canadian research and Canadian guidelines.
Yeah.
So as it stands, the current guideline says that because ablation is not curative of AFib, patients may be asymptomatic, but they may not, you're not curing them. And we don't have data that if you're at risk for stroke before, based on your CHAD-65 score, that ablating and getting rid of clinically apparent AF reduces your stroke risk. Therefore, if you needed systemic oral anticoagulation prior to the ablation because your CHAD-65 score was 1 or more, you had hypertension or diabetes, even after the procedure, even though you may not have any clinically recorded AFib, the recommendation is to continue with it until we get further data. However, if your CHAD score was 0, so you're a 50-year-old young male, no known risk factors in the CHAD-65 schema, then we start anticoagulation a week or 2 before the procedure and continue for 3 months until the endothelial healing happens, after which 6 weeks to 3 months, it varies. My own practice is 3 months, and then we discontinue it. However, Dr. Burney has got a CHR grant where we, like I told you, our whole group is approaching different problems. So we divide and conquer rather than everybody fighting, and we complement each other rather than fight with each other. So Dr. Burney has got the Ocean trial where we are looking at this question. So people who have completed ablation, who have a CHAD-65 score of 1 or more and need to be on anticoagulation, but now have no AFib. He's doing a 5-year study with MRI and stuff. He's going to present that at some point. We're eagerly waiting for that. And then we can tell the people with CHAD score 1 or more who need to continue anticoagulation, whether they can discontinue it if they're not experiencing any AF. And this involves MRI and multiple other things. So it's going to be a NEJM paper for sure when we get the answer to that. I hope that answers the question. To summarize everything, if the CHAD score is 1 or more, the patient should continue systemic oral anticoagulation, even though the patient is not experiencing AF and no AF has been documented on any monitoring strategy.
So maybe I can ask a couple of questions as well. So one is in terms of, I think you showed very nicely in terms of the challenges in terms of ablation success, and there are obviously sort of continued strategies to actually improve on this. And can you force, and of course you're kind of devising solutions and improving stability. So do you think down the road that there could be a situation where one could know the profile of the patients, given the background risk factors, the type of anatomy and the things like that, one would actually know, like for this type of patient, sort of let's say a more aggressive strategy, and the things like that will be necessary versus, somebody who you can say, a conservative strategy likely will give us a, very good success, so that rather than they say, right now you're kind of doing the staged approach, so you can actually kind of say upfront, in fact, for this patient, you get the deluxe package. For this, you get the basic package and you have the good outcome. I guess more on the personalization aspect. Is that something that's possible to do?
Yes. So I'm so glad you asked the question, because, even though I do the procedures, I sincerely believe that that in this field, what we should aim for is that no patient should need a procedure from any one of us. Meaning we need to identify upfront who are at risk, primary prevention, and if we can actually identify individuals very precisely that are likely to benefit from what we're doing, that will be the best. And that's, I think, the goal of precision medicine and personalized medicine. But since those are not my areas of practice, and I don't have the necessary tools to do that, I actually have applied to the precision for Oracle, because one of the things we have realized is, we have extensively done basic research into ablation formation, and we have done this AWARE trial, and we have recognized that, Dr. Isager had serendipitously detected pulmonary vein triggers, and for most patients that work. You isolate the pulmonary veins, and you're good. But what we found is there are a lot of patients, when they come back with AFib, the pulmonary veins are all isolated. There's no more activity there. We did a good job. And they're still having AFib. So we are finding a ceiling threshold for pulmonary vein isolation. Our technique is very good. To improve this technique and get more, we'll cause collateral damage, because if you take a bazooka and blast the inside of the heart, the patient will never have AFib. But then the aorta will go, the esophagus will go. So you can't do that. So our AWARE 2 has recognized the ceiling, and AWARE helps us, really prove that. What we're planning to do is do 2-arm trial, where one arm will just receive the standard package, which is pulmonary vein isolation. The other arm, we are going to do a detailed electrophysiological study to find out all the triggers, low voltage areas, which Dr. Nair is doing the COAST trial on, and see if, in addition to a well-designed PVI, by precision tailoring your ablation strategy using these tools, can you improve the success? And that is why we have applied. So at our level, what I can do is precision in the procedure, but on a societal and patient population level, I think we need to, AFib is a phenotypic manifestation of multiple things. We know there are about 400 genes, last time I read, the ion channels and genes that are responsible for AF.
Yes.
I think I see Dr. Wenbin Liang is there, and he is an expert on that. I don't have to say that, but I think that is the key research at a big, broader level compared to mine. But we are also applying this. That is our next goal. Our 2 is basically, and that's why we applied to Oracle for some root funding, because we want to get at least 60 patients enrolled, so that next time I go to CHR in September, I can say that, okay, we have started rolling out, and we've got 400, we need 600 patients for the trial, which is a large undertaking. And we've got in-kind 600 implantable loop recorders for those patients.
Wow.
The legal services are ironing out the contract. So we can, at a very subsidized price, we can implant that. So our study will be even more powerful. And we hope to see long-term follow-up and, even answer the question, do they have AF? Can we stop them? Make one group fare over the other one? And that is what we decided after seeing our results and all the simulation studies and systematic reviews and meta-regression we did in this field. So it's a long answer to a question.
Yeah, but it's obviously evolving one. And but again, congratulate again on your very thoughtful approach, to answer these questions. And obviously, you're very resourceful in terms of getting the support and getting the studies done. That's fantastic. Yeah. So in view of the time, I'd like to conclude the session here. And again, just like to thank Dr. Girish Nair. Really, actually, very great inspirational story, right? In terms of the journey of answering questions. In terms of addressing patients with atrial fibrillation and making very important inroads, and more data, to change the guidelines. So that's actually the important aspect. And so thank you so much for all the lessons learned. And it's really serendipity, but also sort of being able to have the tools and the questions ready to capture these. So this is fantastic. And so, yes, go ahead.
Can I add a last line, Dr. Liu? I would also like to thank our institution and research services, especially because the research, team and Alison, Brianne, and everybody, they help us so much in design these and get grants. I think our grant success, I was talking to my collaborators from other institutions, and they're amazed by the support we have. So nothing would have been possible without their and your support. So thank you.
No worries. Yeah, but you know, unless we have people with great questions, nothing will happen. Yeah, so thank you so much, and so keep up the excellent work. And just for our next week speaker, Dr. Alex Stewart will give us a insight into genetic mechanism leading to coronary artery calcification. So thank you so much, and thanks again, Girish, and all the best to everybody. Take good care.
Thanks. Bye.